Can you just talk? I'm not going to talk anymore.
You always say that.
All right.
Did you see my email?
I did.
This looks like a SLU laptop.
It is.
Identical to my laptop. That is way too heavy.
Yeah, I think pictorial, at least for me, is helpful.
Yeah.
That's where
And we have promised you would have an audience.
Oh, no worries. I
Yeah, no, I looked at it, I looked at it.
completely understand. This is a bewitching time of day for people, especially if you have any kids. All right, let's see. What do we do by date modified?
Yeah, I
There we go.
think
It's always the last one.
pictures are helpful.
If you want to set up and present this view, you got it.
Nope, I got it. Oh, I think I got it. There we go.
Yep,
I
it
mean,
is.
they're 3 or 4.
And there's always the, about the magic bee. Like if you ever want to just like stop your lecture somewhere, like you're running too long and you feel like you need to stop, you can just make the do B and your next slide is blank. So like sometimes I'm giving a new talk and I don't quite know how much time I'm going to have. I kind of have like 2 potential stopping points, and then I just put the B in, and everybody knows that was the end. It actually, no, because then when you undo the B, you're right
So I
back.
don't know which one's better.
So, yeah, we need to teach each other our tricks. We should like one new cool little trick a day. We'll be totally set. Absolutely.
So very good.
You guys have been keeping us a little bit busier, and we like it.
It's good. The 8 contributions are.
Yeah, but the hepatitis B, hepatitis C,
What
those
did you
are
end
so awesome for my trainees to take care of.
Really?
Yes.
For like 1,000.
Yeah, no, I think it's good because that way they can learn, and that if you see a patient, you've got to make a decision. You're going to remember that.
Yeah. No, it's true. It's true.
Were you involved with the fatty liver and soup?
Oh, that was so sad. Yes, I was. I was actually the hepatologist in charge. You know what? We've seen a few of those, like over the past, 10, 15 years that have been here, and they've done actually pretty darn well. And you get one, yeah, but then you get one that doesn't make it, it's just like, oh. Because you kind of got used to getting them through it. Even though the books all say how horrible it is. I don't know if it's because we picked it up earlier or what the deal was. We had like this really great track record. And this is the first one I know that just really went bad. She just couldn't stop bleeding. I think she was probably more health than fatty liver. I mean, it's exactly like where does one end and the other begin?
The ammonia and
See, that was one of the levels.
So I just gotta go downstairs and turn on the
83, 1. I mean, you can do the anti-inflammatory levels.
Yeah.
But I guess it's too early to do that.
Yeah. With my sepsis, like circle. Of course, I brought my computer too. See, it doesn't look just like that one. I'm getting like shoulder strain from my computer. I said, I'm writing questions for American Board of Internal Medicine for the GI portion. And so, you had to carry like all your stuff. Like, oh my gosh, schlepping that heavy old computer to the airport. It's totally time to get like a Mac Air or something like that.
The next thing is coming, which again, next 2 years. So what's going to happen? You're going to have the actual monitors available everywhere in airports and places wherever you go.
Yeah, so all you need is your keyboard and equipment.
You're just going to need a watch. So your watch is going to be your CPU.
That will be so cool.
It is. In another 2 years, we'll see.
That will be absolutely cool. Hey, how are you?
Number is 790-8022. And if she doesn't call back, you could probably call the 60 phone and see if it works goes where she is. Yeah. Alright, thank you.
think I know just about everybody here, but for those that don't, I'm Charlene Prather. I am a gastroenterologist at St. Louis University. I've been here for going on 18 years now, which is really hard to believe. I am a Missouri native. My mom and dad still live in Jefferson City. I did my training in Kansas City, went to Mayo and did my GI, stayed on faculty there for a stint, and then made the circuit back around to Missouri again. So I've been happy to be here. I deal predominantly with motility and functional bowel disorders. When I'm here at St. Mary's, I basically do it all. So I'm your evening and weekend and St. Mary's hepatologist. And in fact, I've seen more pregnant women with GI and liver disorders than any of my hepatologist friends have. So we're very happy to help with that. We have a fellow here full-time. So 24/7, you can get a St. Louis University GI consult. Most of the private docs, as you know, are scared to death to deal with pregnant patients. Heaven forbid, have to scope them, or give them a drug. So that's a great learning opportunity for my fellows. I'm the fellowship program director. So I wear that hat as well. So today I bit off an overly ambitious topic. And so what I think we really need to do is I think I need to just come here like every other month to kind of go through kind of the practical aspects, because when I started putting this together, I was like, what was I thinking? This is like 80% of the GI disorders that are seen during pregnancy are going to be kind of the functional ones. We know that GI symptoms are incredibly common. I'm preaching to the choir here if I'm going to tell you about nausea and vomiting. You guys are better at managing nausea and vomiting than we're going to be because you do this all the time. So I thought heartburn is one of those ones that you also see quite a bit. There actually is a little bit of science in the literature about gastroesophageal reflux disease in pregnancy, so I thought we'd talk about that. And I'll leave some time at the end if there are like some pressing questions about other GI disorders and you're interested in my approach to them. I certainly have a fair number of patients with irritable bowel syndrome. That's a disorder of, if I want to be, stereotypic, young women in their childbearing years, ages 20 to 40. Their IBS, may stay the same, sometimes gets worse during pregnancy. And so I've certainly had to help many of my patients through those, what are sometimes very long months when you're having daily GI symptoms. So we're going to talk about gastroesophageal reflux disease. I'll kind of talk about what it is, what causes it, what information do we have related to pregnancy, how do we diagnose it, and how can it be treated? What are the options that we have? And again, I try to bring something, so we've got students here, all the way up to incredibly experienced MFM professionals. So a little bit of something hopefully for everybody, but for the students, we keep it simple. Gastroesophageal reflux disease is nothing more than the backward flow of gastric contents into the esophagus. The typical symptom is burning behind the breastbone and called heartburn. So it's pain beginning here, radiating up into the chest. If the pain is just here, that is not gastroesophageal reflux disease, at least not typically. We would call that dyspepsia. So for it to be gastroesophageal reflux disease, there actually has to be some radiation or some movement, into the chest itself. Again, something that commonly gets confused clinically. All right, let's see. So it can be a variety of manifestations of reflux disease. This is certainly on the more serious end. We see actual erosions in the esophagus and changes in the mucosa of metaplastic tissue that likely represents Barrett esophagus. So the common symptoms that we talk about are going to be the heartburn. Sometimes patient will call it indigestion. Regurgitation is certainly an incredibly troubling symptom for many of our patients. Belching, excessive gaseousness. Less common, and ones that we're often called to comment upon, are symptoms of unexplained chest pain, cough, hoarseness, wheezing, postnasal drip, sinusitis. I mean, you name it. If it's kind of in this sort of area, if they can't figure out what it is, they call it gastroesophageal reflux disease, whether it is or it isn't. They put people on a PPI. It doesn't work. Let's give them more PPI. There may be a more rational approach to kind of managing those patients, and those are ones where physiologic testing is likely to be helpful. So heartburn. It's an incredibly common complaint. Just in the general population, 40% of individuals in the general population, age 18 and above, report at least one episode of heartburn monthly. 20% actually have it several times per week. You're understanding now why there are all those commercials on television with anything from antacids to, you know, the purple pill that they're trying to get you to buy. And 7% describe weekly symptoms. In pregnancy, there's fairly broad range, kind of 30 to 80%, depending on the study that you look at and what trimester. However, if they had symptoms prior to pregnancy, chances are they're going to continue to have symptoms. There's nothing about pregnancy that makes heartburn less likely, except they do stop smoking, hopefully. They do stop drinking alcohol, hopefully. I know that we're here and we sometimes struggle with that with our patients. And hopefully they eat better. So there are maybe some, you know, so if they were to improve, it's because maybe they start to incorporate some healthy lifestyle changes that they had not done before. So if we take a look at information that we have from the literature about how common heartburn is and what are perhaps some predictors of heartburn in our pregnant patients, using a validated measure, so not just asking, do you have heartburn, don't you have heartburn, they're actually, believe it or not, validated questionnaires just for gastroesophageal reflux disease. Nerds like me live for that kind of thing. We like our questionnaires. In fact, I think one of my medical students I'm working with is hoping to work with the endometriosis group, taking a look at IBS overlap in patients with endometriosis, which we know, but it's not been carefully looked at using a validated questionnaire. And for the students, those are great studies to do because they're relatively straightforward. If you have a very focused question, you can, you know, help by getting the questionnaire out. The data are there. It's something that you can do more on evenings and weekends as opposed to some of the other clinical research that we do. So that's what they did in this one. What they found is, you know, in the third trimester, between 25 to 50% of pregnant ladies will have heartburn, and 50%, almost 50%, have regurgitation. So incredibly common. The risk factors are increased weight gain, and also, obviously, as I mentioned, they had heartburn before, or reflux before. You know, the odds are at least 4 times greater than an individual who did not have heartburn before, that that's going to be ongoing during pregnancy. GERD-related symptoms in pregnancy, they may, you know, about 9% will have non-cardiac chest pain, up to 13% dysphagia, cough, 26%, belching, often associated with some regurgitation, 66%, and hiccups, about 19%. So there are some associated symptoms. So what causes gastroesophageal reflux disease? Well, the stomach normally produces acid, but not everybody gets heartburn. But some of the acid escapes from the stomach into the esophagus and perhaps sits there, you know, for a while. GERD occurs when this acid exposure to the esophagus is excessive. So, especially for the students, gastroesophageal reflux disease is not a condition of excessive acid. It's too much acid in the wrong place. So acid is important. It certainly serves a function for us physiologically. The other thing is that why does acid stay in the esophagus longer than it should? Well, if you have weaker motility in your esophagus, something known as ineffective esophageal motility, you don't push that acid out as readily. So usually if we have acid come into our esophagus, we actually salivate more. Saliva helps neutralize the acid. We also have secondary peristalsis. I'm sure you remember that, you know, the phase 2 module that I told you guys through. That secondary peristalsis is an incredibly important mechanism, especially at night when you aren't consciously aware to swallow, of getting acid out of the stomach. And those are reduced in patients with gastroesophageal reflux disease. So hopefully you remember this slide from the phase 2 module. The goal of the esophagus is to remain empty. So we shouldn't be getting gastroesophageal reflux disease because we should be getting rid of that acid whenever it's there. So normally, when we take a look at the esophagus, so this is the gastroesophageal junction right here, that's the stomach, the rugal folds right there, this is the squamous mucosa, looks pretty normal. This is actually a fairly typical image of what we'd see in reflux disease. For one, it's not closed down. You know, it's open. Now, you know, if I just put a bolus in of air, that's going to generate peristalsis in the esophagus, even during endoscopy, and cause the LES to open. But then it should close back up again. It shouldn't just stay open. So when the LES just stays open, and this is present in probably 15 to 18% of individuals with reflux disease, that they actually truly have a weak lower esophageal sphincter, you're going to be more likely to get that acid coming up because there isn't a barrier there. This is what we see in patients with more severe esophagitis. So we grade esophagitis from A to D. The picture I showed you isn't even a grade. Grade A is just a little erosion. This is grade D, where you've got circumferential ulceration, which is the most severe form of erosive or ulcerative esophagitis. Fortunately, it's not all that common. But in our pregnant ladies who come to endoscopy, because of weight loss, severe dysphagia, odynophagia, we're much more likely to see more severe reflux changes, just because there's a selection bias. We don't do an endoscope on every patient who's pregnant who has reflux who we aren't easily managing. It's important to recognize that the severity of the heartburn itself does not correlate with the degree of changes that we see on endoscopy. The exception about that is going to be if they have odynophagia. So heartburn, and even severe heartburn, doesn't predict whether they're going to have erosive esophagitis or not. But if it hurts when they swallow, they are much more likely to have erosions or ulcers in their esophagus. When do we worry in pregnancy? Well, if they're having, significant dysphagia, again, you saw in heartburn, up to 12% actually have dysphagia. We don't necessarily scope all of those during pregnancy. But if they're having hematemesis, inability to gain weight, or painful swallowing, those would be individuals who you'd want to consider investigating sooner rather than necessarily waiting until they're not pregnant anymore. So the triggers for reflux disease are the same in pregnancy as they are in individuals who are not pregnant. Large meals, kind of like a perfect one here, some fatty meatballs, red sauce, tend to contribute to reflux. Alcohol, hopefully not in pregnancy. Chocolate, I know plenty of pregnant ladies who like to eat their chocolate. Yes, indeed, chocolate is great at inducing reflux. Coffee, even decaffeinated coffee, can result in acid reflux related symptoms. So if they're drinking coffee, even if it's decaf, that would be something that you'd want to suggest that they eliminate. Tobacco, hopefully not in pregnancy. Certainly we know that some of our patients do continue to smoke. We know that individuals that smoke tobacco have double the reflux events as individuals who don't smoke. This is like not controlling for heartburn. Just taking a look at a population of those who smoke, those who don't smoke, doing 24-hour pH monitoring, little tube that's put in the nose, down into the esophagus, measures pH, double the number of reflux events if you smoke. So hopefully not in our pregnant patients. More the supine position than actually on your side, but certainly if you go to bed too soon after you've eaten, what we like to recommend is to have liquids only within 4 hours of bedtime. Within an hour of bedtime, I prefer water only. Beverages that you drink and then you lay down certainly can contribute to regurgitation, especially during pregnancy. Certainly good nutrition is important. I don't want to have my patients overly fasting. But these, if you understand the triggers, things that you can do to counsel your patients, because, most ladies that are pregnant would prefer not to take medications if they don't have to. Although we know that's not true at all. Obviously pregnancy, that's what we're talking about. And we also saw that, if you gain weight excessively during pregnancy, and weight gain if you're not pregnant, you are more likely to have acid reflux. So you can see the reasons why reflux is common in pregnancy is, weight gain, just like not in pregnancy, but obviously during pregnancy you're expected to gain some weight. Dietary indiscretion, certainly something to take a look at and see what can be done to improve their diet. Hormonal changes, certainly there have been some studies that have correlated that. I got to say those studies are pretty darn weak. We know that progesterone has a direct relaxing effect on the lower esophageal sphincter, estrogen less so. And abdominal pressure, we know that reflux-related symptoms are more common in the third trimester than they are in the second trimester or first trimester. If they did not have reflux symptoms before pregnancy, it generally always resolves post-pregnancy. Interestingly, older maternal age is actually protective against getting reflux, so I thought that was kind of interesting. So, all right, so let's see. So the physiology of heartburn. So what we know that in pregnancy specifically, the basal lower esophageal sphincter resting pressure is less responsive to stimuli that help the esophagus contract. So you may remember gastrin. Gastrin is released in response to eating. Gastrin induces acid secretion from the stomach. We know that gastrin also is associated with an increase in the normal situation of lower esophageal sphincter pressure, because if your stomach is filling up with food, you're going to be producing acid. It makes sense protectively that the LES would be stronger. We know that they've actually done manometric pressures in pregnancy and find that the lower esophageal sphincter pressure is indeed reduced by 30 to 50%. So now normal lower esophageal sphincter pressure is kind of in the 15 to 25 sort of range. You really don't get like free reflux until you're below 10. If your lower esophageal sphincter pressure is below 10, you have free reflux. If I can take a look at a manometry in somebody who's not pregnant, and if their pressure is less than 10, I can say, you know, if medicines are doing the job, great, but you are likely to always require medicine for your acid reflux. That's someone who may benefit from a fundoplication if they prefer not to take acid reflux medicines on an ongoing basis. Estrogen has been reported as a primer for heartburn, but progesterone is the one that mediates relaxation that usually carries the shoulder of the blame there. So, how's GERD diagnosed? Pretty much the same in pregnancy as in the non-pregnant individual. If they have typical symptoms, if they respond to the lifestyle changes that we talked about, or relatively simple acid suppression, that's good enough. Absence of worrisome symptoms. So symptoms in pregnancy that would be worrisome. Certainly hematemesis, theodinophagia, significant dysphagia, not just occasionally something sticks there a little bit, but they're regularly having trouble getting their food down. And failure to gain weight properly is another symptom that might be more worrisome. When will we do endoscopy? When we do endoscopy, really the main reason is to detect complicated reflux disease. Do they have erosive esophagitis that needs more aggressive therapy? Or do they have a stricture or narrowing where if I do a dilatation, I'm going to improve their ability to eat? Do they have an infectious esophagitis? Again, you know, certain individuals are going to be at greater risk for that. You know, gestational diabetes, maybe HIV positive. They're already immune suppressed, but pregnancy alone is adequately immune suppressive that we do see greater esophageal pathology as it relates to infection. Most commonly, Candida is the most common one that we see. Barrett esophagus, you know, I just don't worry about that in my young women. This is predominantly a condition of Caucasian men over the age of 50 who've had 10 years of acid reflux or more. Absolutely appropriate to screen for it in individuals who have chronic ongoing reflux. Not a concern in pregnant patients. We also do endoscopy because are we sure about our diagnosis? Are we missing something else that we might treat differently? Is everybody here familiar with eosinophilic esophagitis? It's like the thing right now in esophageal disorders. So eosinophilic esophagitis occurs more commonly in atopic individuals with asthma, and it's an abnormal accumulation of eosinophils in the esophageal wall. It greater than 25 per high-powered field. The main symptom is heartburn and dysphagia, so food sticks. So if you've got somebody with those symptoms, especially if they're relatively young, especially if they have a history of asthma or allergies, they have a greater likelihood of having this diagnosis. Now, they may be responsive to PPIs. If they are, that's great. You don't need to go any further as long as their dysphagia is improved. But we would recommend topical steroids if their symptoms are not improved with acid suppression. And so, you know, fluticasone inhalers that we use for our patients with asthma, that's what we use for treatment. But instead of using good technique, we ask them to use bad technique. You spray it in, you swallow 1 to 2 tablespoons of water. You want it to have residence time there for at least 30 minutes. You don't want them to eat for 30 minutes. I usually have them do it in the morning before breakfast, at least 30 minutes, at night before they go to bed. It works like a charm. For the occasional refractory patient, we can use topical budesonide, but that's a little bit harder to get. You have to get that at a specialty pharmacy. You can also, you know, you need to understand why they have it. In adults, it's more likely to be related to kind of swallowed aeroallergens. So when we swallow, we're always swallowing, a tablespoon or two of air. And that topical exposure to aeroallergens can be enough to cause the eosinophilia. But the other things that we consider are milk products, which obviously in pregnancy they may have increased their milk consumption. And so that may have kind of caused them to have a flare. Seafood can do it. Soy is another one. And so we can actually put them on an elimination. Nuts is another one. So we actually can put them on an elimination diet, see if their symptoms improve, and then we can add one of those back in. They certainly can do allergy testing, but that's not always completely diagnostic. So that's important. Piloesophagitis. So piloesophagitis is going to occur with certain pills that we sometimes will use. Obviously, we're not going to be using doxycycline in pregnancy, so that one's pretty much off the list, but classic for causing this. And you certainly use it in other conditions, post-pregnancy. Potassium pills, iron pills. Most of them are not taking aspirin, although sometimes they do, certainly aspirin. Hopefully they're not taking non-steroidal anti-inflammatory drugs, but those can do it as well. So if they've got a pill that causes difficulty, that's somebody who, you can consider the pill and treat them for that, but if they're not getting better, you need to take a look, because they can sometimes get a pretty deep ulcer for that. We talked about their risk for infectious esophagitis. In pregnancy, stomach emptying is also slowed. And if your stomach isn't emptying well, you're more likely to have acid regurgitation. And so that's something that if we do an endoscopy and we see food in the stomach or a whole lot of fluid, that tells us the stomach's probably not emptying that well. The other way we diagnose gastroparesis is a nuclear medicine gastric emptying scan. Obviously not something that we're going to do in pregnancy, but there actually is a stable isotope that can be used in pregnancy. It's not available here at St. Mary's, but it's a carbon-13 radioisotope that's labeled to spirulina or octanoate. And so they ingest this muffin that contains this. It's absorbed in the small intestine and then exhaled in the lungs, and there's a mathematical formula that you use to then calculate gastric emptying. So we may be able to test gastric emptying in pregnancy in the future. So who do I consider doing an endoscopy in pregnancy? If it's just failure to respond to a PPI, I'm usually going to wait until post-pregnancy unless their symptoms are quite severe. Yeah, I'm sorry, but in balance, even though the risk of endoscopy is small, it's not nothing. And especially if it's in their third trimester, I'd really prefer not to do an endoscopy in the third trimester unless I really have to. If they have a dynaphagia, and something that with my initial measures that over, several days to a week, depending on whether they're hospitalized or not, they're not improving, we need to take a look at that patient. They need to have moderate to severe dysphagia, not just that it's sticking now and then, but it is limiting their eating, their ability to gain weight because they're not able to swallow. Because I may be able to do something therapeutic. If they're vomiting blood, and I'm not talking about just a little speck of blood or maybe a little bit of coffee grounds after they've been retching for a while, but if they're vomiting up a cup or two of blood, we need to take a look. Intractable vomiting, not just a little bit of nausea and vomiting that you might see in the first trimester, but if they can't, if we can't get control of their vomiting with usual medications that we use, looking for something else as contributing to their symptoms is important. Weight loss or failure to gain weight appropriately, if the GI symptoms are the reason for that. And if they have significant medical comorbidities, if they have HIV, if they have diabetes, they're more likely to have more complicated disease. So those are individuals that I might tend to do an endoscopy earlier rather than later. Another one I want you to think about is if they've got refractory symptoms in the setting of gastric bypass or lap band, they're more likely to develop complications as well. And if they have refractory symptoms, I might scope them sooner. So you guys are probably familiar with the lap band, at least hopefully you are. Again, a device that's wrapped around the proximal part of the stomach. It's got a little hose right here. It comes out to a reservoir that they can, inflate to make the lumen more narrow or deflate to make it more open. There's up to a 50% complication rate with the lap band, which is not usually advertised in those commercials that we see. These can erode through the gastric mucosa. they can cause an achalasia-like syndrome where they're constantly regurgitating everything they eat, even when they let the lap band down all the way. What happens is that the stomach dilates and the esophagus dilates too. It becomes like this common tube. And even when they let the lap band down all the way, what has happened is that there's scarring around the lap band. So unless you actually take the lap band out, which is no guarantee that you're going to get better because it depends on how bad your motility is gotten. But that's definitely a problem. These lap bands can also slip and cause obstruction from slipping. And so if you've got a patient who's had prior gastric bypass surgery or a lap band, you want somebody to do the endoscopy that actually knows what they're looking at. Because what often happens is you hear, oh, the patient has a hiatal hernia. Well, they don't have a hiatal hernia. They have a narrowing from the band. And so you want somebody that knows how to take a look for those sorts of abnormalities. But those are kind of scary when they occur. And we've actually removed endoscopically a lap band that had eroded all the way into the stomach. So that definitely can happen. Obviously, a CT scan in that individual, that was not a pregnant individual, showed that there was nothing on the outside, so that was safe to do so. So I will tend to take a look at those folks sooner just because they are at a higher risk of complications. So endoscopy is the best way to evaluate mucosal injury. And those with refractory symptoms who aren't pregnant, we find erosive esophagitis in about half, Barrett's in about 10%. Because of the selection bias of we're only scoping those with the most severe symptoms in pregnancy, we find abnormalities, 2/3 to 90% of the time. So pretty high rate. So for the students, when in pregnancy is our best time that we like to do endoscopy? Like if we have to do endoscopy, what's our preferred time? What would you think? Just thinking about what you know about pregnancy and physiology. Any idea? Got a 1 in 3 chance of being right. It's first, second, or third trimester.
Second.
Yay! Absolutely. So obviously, you do what you have to do regardless of what the trimester is. But from the GI literature, the safest time to do an endoscopy is during the second trimester. And the problem with the first trimester, I don't know if it's necessarily unsafe, and certainly the drugs that we use for sedation are not that scary of drugs in pregnancy. But that first trimester is such a high risk time anyway for miscarriage that if you do an endoscopy and they have a miscarriage, well, was it because of the endoscopy or were they going to miscarry already? So just to kind of stay away from that drama, we do try to avoid doing endoscopy in the first trimester unless we've got a really good reason to do so. Second trimester, we really don't worry about it. That they tolerate it beautifully. Medications are really not much of an issue with conscious sedation. In the third trimester, it's mostly, there's got to be a really good reason to do it. But also just because of blood flow sort of issues to the baby, you've got to be a bit more careful about positioning. So we do try to avoid it if we can. Although, as you guys know, we've scoped plenty of patients in the third trimester if we've had to do so. So how do we treat GERD? Well, just empiric treatment is what we usually do, certainly with classic heartburn or absence of warning symptom. We have a variety of options for our patients, and our patients often will choose to self-treat. Lifestyle modifications first. You see the great big old sandwich with the pickle on top. Probably a bit higher of a load of nutrition than you'd want to get. So certainly talking to them about the things that we talked about that precipitate reflux, you'd like to tell them what to do to reduce their likelihood of reflux. And they do indeed work by improving physiologic mechanisms. When I gave this lecture 10 years ago, I said that we had no data to say that this actually worked. Well, in fact, now there actually are data that show that you do improve reflux disease by improving your changes in your diet and your lifestyle, so that's good. Typically, these work best for those with mild or intermittent heartburn. Certainly prevents the need for drug therapy, and the cool thing is it doesn't cost a thing. Next step is typically antacids or alginic acid. Do you know what alginic acid is? It creates kind of this foamy barrier on the top of the stomach. So the one that does that is Gaviscon, is the one that does that. So they transiently neutralize gastric pH. They do have common side effects. The ones with aluminum and calcium certainly can be constipating. Those with magnesium, they can certainly get diarrhea. And, you know, even if you're not pregnant, you can get metabolic toxicity with the magnesium or calcium with abnormally high blood levels, and that certainly can happen in pregnancy as well. The cost, not exactly cheap. Again, these aren't sale prices, and these aren't generic prices, and certainly you can get the generics. But compared to other agents that we have, they're relatively expensive, because if you get a bottle, you know, if you're taking it according to the directions on the bottle, it might last you 10 to 14 days. So they can be expensive. Remember milk alkali syndrome, mostly for historical purposes, because people don't really do this anymore. This is before we had good medications to inhibit acid. So back in the 70s, you know, before all the acid suppression, before I know the people in the front room were even born, this was a common problem. And, you know, in pregnancy, you are drinking more milk. Calcium's good. Let's get my Tums as well. So there could be an increased risk. And, you know, 2 grams of calcium per day is not that much. You know, a dose of extra strength Tums is about 500 milligrams. So you can imagine if you've got heartburn and you're chewing Tums like candy, you might be at risk for that. The other antacid that you typically want to avoid during pregnancy, and honestly, besides my father, I don't know who's ever used it, is sodium bicarb. So good old-fashioned baking soda and water. It actually works. That's something you wouldn't want to use during pregnancy. Yeah, I remember my dad doing that in the middle of the night, drinking his bicarb. So.
But patients have grandmothers that still tell them to do that.
Yeah, and so you do, and it is something that specifically you should recommend against doing. So we'll talk kind of about that as well, because that actually comes back to play as it relates to some of our medications that people might not think about. So we actually have a variety of over-the-counter medications, and our patients have access to those, be it the H2 receptor blockers, Tagamet, Zantac, Pepcid, Axid. Most are half of the prescription dose. There's no reason not to use full prescription dose in patients with acid reflux. The nice thing about them is they have a very rapid onset of relief. You know, they're going to get relief within about 30 minutes. Gastric acid is reduced about 85% over that first 4 hours. They have a great safety record, no GI side effects as seen with the antacids, and pretty much all of them are pregnancy category B. They're considered safe to use. The cost, relatively inexpensive. These are the over-the-counter. Now, in contrast to ulcer disease, where you can dose H receptor antagonists once daily, if you are treating true gastroesophageal reflux disease, you really need to dose it twice a day. So if your patient's not getting relief, find out how often they're taking their medication and whether they're taking the full dose. Now there are stronger over-the-counter acid blockers, are proton pump inhibitors, Prilosec, which is a omeprazole, Zecred, which is a omeprazole plus bicarb, and Prevacid, I think, and there's also Nexium. I forgot to put that one up there now. These block the acid pumps from working. They take 24 to 72 hours to kick in. They are not medications to be used PRN. If you want a PRN medication, use H receptor antagonists. If you're choosing to put your patient on a proton pump inhibitor, you got to have this discussion with them that you need to take this every day to work. It's going to take 2 to 3 days before it really kicks in. Those should be used. And what's my cutoff? If they're having symptoms, you know, 3 out of 7 days or more, and or if it's interrupting their sleep, that's somebody who should be treated with stronger acid blocking medication. Just looked this up yesterday. These are relatively inexpensive now. Lansoprazole, which is the one that I recommend most commonly during pregnancy, is 40 cents per tablet, which is not too bad. I tend to avoid omeprazole just because I have safer options. You know, not that it's like terrible in pregnancy, but since I have safer options that aren't necessarily more expensive, why would I not use the safer option? Another over-the-counter medication is Pepcid Complete. I think it may be available as a generic, although I've not seen that when I've gone to look for it. But it's a combination of famotidine, you know, an H2 receptor blocker, and an antacid, and basically calcium carbonate. So the beauty of it is that you get that immediate relief, like within minutes, from the calcium carbonate, and then it kicks in to last for that 4 to 12 hours when the H receptor antagonist kicks in. And it's really not terribly expensive either. Well, what if over-the-counter's not working? Well, especially in this day and age of protein pump inhibitors, I'm going to double check and see what dose they're using. I'm going to ask them how they're taking it. Don't ask, Do you take this before breakfast? Oh yeah, doc, I take it before breakfast. Tell me how you're taking your medication. Oh, I take it with breakfast, or I take it before I go to bed. What you need, if you explain to your patients how these work, they'll be much more likely to be compliant. So these are great medications. They actually block the acid pump from pumping, but they only block the active acid pumps. Our acid pumps aren't always pumping out acid. Most of them are actually quiet. What stimulates acid production? Eating a meal. So take your medication 20 to 30 minutes before you eat. That allows it time to get into your bloodstream. Then you eat. Those acid pumps start pumping out acid. It shuts those off permanently. Those will not reactivate. Now you create new acid pumps every day, so that's why you have to keep taking the medication. But you want to make sure they're taking it correctly. And if they're taking it twice a day, it shouldn't be before breakfast and before bedtime. They all think, oh, before bedtime because I'm having acid reflux symptoms at night. You want them to take it before their evening meal, and then preferably you want them to fast, at least from solids for 3 to 4 hours before they go to bed. So, all right, so prescription ones, remember that the H receptor antagonists are $4 a month on almost every, Walmart, CVS, Kmart, Schnucks, whatever, drug plan of generics. $10 for a 3-month supply, so very economical. Proton pump inhibitors, those are the main ones that we have to use, and like I mentioned, I tend to avoid omeprazole. Oh, and dexlansoprazole, I forgot about that one. That's the one, Dexilant, that's the only one that's not available over the counter anymore. They are most potent agents for acid suppression, permanently block the acid pump, heal complicated esophagitis, have an excellent safety profile. They're all good drugs. The one that works and is most cost effective is the one that I recommend. Prices, omeprazole is the cheapest. Zegred, so remember Zegred is that combination of the omeprazole plus sodium bicarbonate. So it's kind of like a double whammy of things I prefer not to use since I have other choices. So if they're not pregnant, those are fine. But the rest of those are generally fine to use. Dexilant is still prescription, so why would you use a $139 drug if I can get a 21, or if I have to double the dose, $42 drug a month. So $1 a day really is not too bad. And again, I didn't put all the different generics up there. Some of the generics are a bit less expensive as well. And they all work well. Some subtle differences to know if your patients have trouble swallowing tablets, acid-affecting for tonics or tablets. We don't use Prilosec. Prevacid and Nexium can be opened and given with applesauce if they have trouble. Don't use Zegred in pregnancy. Prevacid is available as a suspension and as a rapid dissolve tablet, so that can be helpful for those that are having some difficulty swallowing pills. And generally speaking, Nexium has the greatest degree of acid suppression, for the price. So that's kind of a moving target right now. So do we need to worry? So the things that we worry about, obviously, in pregnancy are going to be, are the medications safe? These are safe medications. Are they getting inadequate nutrition? So that's a time when I'm going to be more likely to treat the reflux disease more aggressively. And, what's their quality of life and what are their sleep habits? Because, there are a lot of things that go in to deciding when is it right to kind of jump to, perhaps more aggressive treatment with higher doses of medications. Interestingly, they show that, how, and these I'm sure are probably, even though it's, a study, it was published in a peer-reviewed journal. I'm sure it was pharma-sponsored. But what they say is that individuals with gastroesophageal reflux disease have a worse quality of life than class 3 congestive heart failure and individuals on chronic hemodialysis. Personally, I have a hard time believing that, but that is what the literature does say. So are these medications safe? Safety is obviously something that we worry about. Proton pump inhibitor exposure in the first trimester, and this is a Danish cohort study of which they have good overall collection of data from 1996 to 2008. As you can see, the adjusted odds ratio was 1.1 with the confidence interval crossing 1, indicating that there was no significant problem with the use of proton pump inhibitors in the first trimester as far as teratogenic sort of effects. A meta-analysis took a look at this. They took a look at 60 different articles, 7 met their strict inclusion criteria. The risk of major malformations, the odds ratio is 1.1 again, but again, crossed 1, 0.86 to 1.4, so not significant. Same with spontaneous abortion, same with preterm delivery. So again, these seem to be very safe agents for use during pregnancy. Is bigger better? Well, I mean, use the amount of acid suppression that the patient requires. If you're requiring a double dosing of medication, you know, I'd recommend just changing to a higher dose of the same medication. It's easier to take something once a day than twice a day. Assure that there's optimal timing with meals. You know, even in my clinic, and I explain these to my patients, when they come back again the next time, at least a quarter of them are still not taking their medication correctly. So they don't hear you, they don't understand. Definitely follow it up. Just because you told them once doesn't mean they're doing it right. And sometimes I'll change to a different proton pump inhibitor just because there's different pharmacokinetics. Some individuals metabolize medications differently than others. If not responding to large dose PPIs, you know, I'll consider a pH study. These are safe to do during pregnancy. This is a little tube that I put in through the nose and into the esophagus, but you know, for the most part, I'm going to wait until post-pregnancy if they're having refractory reflux. But I do want you to consider alternative causes of their symptoms. Are you missing gastroparesis? Are you missing an infectious esophagitis? Are you missing eosinophilic esophagitis? What are other things that are keeping your patient from responding? What is the impact of those symptoms on their quality of life, on their pregnancy? You know, do we need to go to the next step of diagnostic testing? So the classic paradigm, which has been questioned for treating reflux disease, and you know, reducing visits to the doctor, improving overall outcomes, was actually a top-down. That you hit them hard with the PPI, and then you kind of, you know, work your way down. So it takes them a while to get their lifestyle modifications. You kind of work from the most effective to the least effective. In pregnancy, we're more likely to do a step-up sort of therapy. Lifestyle modifications, occasional, not continuous antacids, over-the-counter or starting with H2 receptor blockers, you know, including higher dose, twice daily H2 receptor blockers. PPI, you know, sometimes before I'll jump to a PPI, twice daily, I'll give a PPI in the morning before breakfast and H2 receptor antagonist in the evening or before they go to bed. And so just kind of finishing up here, this is, well, dear colleagues, this is definitely the most severe case of heartburn I have ever seen. And certainly brings the point that for the patient who has heartburn, these are serious and important symptoms to them. So I think I'll finish up right there. And just for the students, pearl for the day, just to kind of break things up a little bit, rodents do not vomit, in case you wanted to know. Now, there is an exception to this, which is the ferret. Ferrets do. So just in case you ever wanted to know. So, but thank you guys very much for having me here, and I'll be happy to answer some questions. Well, they do vomit. Yeah, just so you know. Of all the rodents, so but I never knew that.
So for the patient that needs to take, say, an anticoagulant, and they also take, say,
Yeah.
on a daily basis.
Yes.
So how are you going to use your antacid therapy to prevent complications?
All right. That won't work. Now, high-dose H2s actually may, and there are some data for that. But in that individual, I'm most likely to use lansoprazole, 30 milligrams once daily. Actually, 15 works as well. So if they're not having acid reflux symptoms, you can use the lower dose. But that's somebody just to reduce the likelihood of complications. And because these medications are so safe, I am going to put them on that.
But how about the timing of the treatment of the antacid API?
In the morning before breakfast, same exact
And the
one.
timing of the medication?
They can take those per their routine. You know, there's, as you may have heard, especially with omeprazole and clopidogrel, there was this concern about an interaction. Turns out that's not as big a deal as what we think it was. If you do choose to use those two together, probably the better part of valor is to give them at different times. That way they're being metabolized at different times. We metabolize our drugs actually pretty quickly when we first take them. So you could take one in the morning, you know, one in the evening would be an option for that. The aspirin doesn't matter. They can take the aspirin whenever they want. Well, the meals only affect any contact irritation from the aspirin, since it's really the cyclooxygenase inhibition that contributes to the ulcers. That's a bloodstream-borne effect, and so it doesn't matter whether you take it with meals or not. So. Another question I often get asked is like, are proton pump inhibitors safe? You know, what about magnesium? What about bones? You know, for how potent these drugs are, they are incredibly safe. Yes, you do perhaps have a little bit less absorption of calcium because you don't have the acid there. It's really not a big effect, not something that, you know, I'm going to overly worry about unless it's somebody who's going to be on it for years and they've got a family history of osteoporosis. Then I kind of have to weigh the pros and cons. Magnesium is a big deal, more so with the omeprazole, perhaps, and Nexium than some of the others. If they're at risk for low magnesium, you know, I may check that. Who would that be? Patients I'm choosing to put on diuretics. So if you're on diuretics and you're taking a PPI, I would probably check magnesium at least once. B12, again, a theoretical risk. There are other reasons for B12 deficiency. Even the most potent proton pump inhibitors do not cause complete achlorhydria. So usually if you're going to get B12 deficient from a PPI, it would be decades later, not something that's going to happen in the short term. And it's something that you can easily overcome with a simple multivitamin. Not going to be an issue in pregnancy because most of our patients are on prenatal vitamins. The other one is pneumonia, increased risk of pneumonia if you're on a proton pump inhibitor. Now what you do, that is actually real and important, but only in the first month. So you don't need to take somebody who's been on a chronic PPI off because they've got an increased risk of pneumonia. But you better watch, especially for the students, your older patients that you start on a PPI, like in the hospital, make sure they really need it. Because their risk of pneumonia is double, 2 to 4 times that of similar individuals who are not started on a PPI. So it's that first month you got to worry about. The other thing is if I do have somebody with recurrent C. diff that's on a PPI, I will look for other alternatives because their risk of C. diff with a PPI is identical to antibiotic exposure. So that is the group that I will take a look at. So that's my quick and dirty treatise on what you need to know about side effects of PPIs.
Is there antibiotics that you wouldn't give because they increase the risk for C. diff if they're on a PPI?
I would prefer that they not be on Cipro. If I have a choice, and obviously if they're not pregnant, doxycycline, minocycline is great. Bactrim, trimethoprim, sulfamethoxazole, is fine. The ones that I really like to avoid, clindamycin, again, something that is used sometimes in pregnancy because it's pretty darn safe. Cephalosporins are the other one, and the quinolones. Those are the 3 biggies. As far as that goes.
About like stress prophylaxis in patients, especially post-op, like say we have patients with C-sections.
Yeah. The risk is honestly for that group relatively small. The ones that are requiring ventilation, if they require ventilation, that's the group that I want. If they're on, as mentioned, antiplatelet agents or anticoagulants, for other reason, that's somebody I'm definitely going to want to prophylax in the short term. But if they're not being ventilated for, prolonged period of time, I don't really worry about it. Well, the thought is that it relates to colonization of the stomach from not having acid there, and that it's, kind of a reflux or aspiration sort of thing. But we don't know. These were epidemiologic studies, and so we actually don't have good lab-based data on what the mechanism is. It's just a guess. So, it's kind of interesting. Yeah.
But when people get some loose stools from magnesium-based antacids, do you just I just remember being taught to give them some aluminum-based.
You certainly can, and that's why many of the antacids are that way. The other thing you can do is you can break it up. So magnesium is transported by the divalent cation transporter in the small intestine. It has a limited ability. This is the same transporter that transports calcium. So you don't want them to take their calcium and magnesium at the same time for that. But let's say you want them to be on, you know, 500 of magnesium a day, rather than giving it all at once. If you break it up during the day, you're more likely to absorb it and less likely to cause a laxative effect. If I'm using it for constipation, I want them to take it all at once. But we also use magnesium for individuals, for example, with migraine headaches. It's a common treatment for migraine headaches as well. So, but yeah, absolutely adding a little bit of aluminum, you know, hydroxide antacid is fine. You know, I have had more trouble finding those in the pharmacy. It used to be like Alternagel, Amphagel, but they aren't really as available anymore. I'm not sure why. Like aluminum and the whole Alzheimer's thing got people away from taking aluminum-containing things, even though it wasn't scientifically based.
Patients have been telling me that all of the antacids
Are harder to find, yeah. Well, I think just with these other agents have gotten so much cheaper and more available that they're taking up more shelf space, and the antacids, you know, relatively less shelf space. I've noticed the same thing. Because one of the things I do when I go to the grocery store, I go to the pharmacy, I always look at the GI section to see what's out there that my patients are probably taking.
Isn't there something in the, talk about PPIs and fractures?
Oh yeah. So there is. So the story is, you know, this was a study that was done, you know, I believe in the United Kingdom. It was an epidemiologic study, and they looked at exposure to acid suppression, and they actually had it controlled for ACE receptor antagonists, and they showed that the risk of hip fracture in individuals who had been on it for, I think it was more than 10 years. I need to double check that paper, so don't quote me on that. But was double those who were not on proton pump inhibitors. But the overall relative risk of fractures was incredibly small. And so that's where it comes to that if I've got somebody who needs to be on a long-term PPI, I'm going to be concerned about their bone health. I'm going to check a DEXA scan if they're at risk. I'm going to check a vitamin D level, although insurances don't cover that. My last patient had to pay $600 for their vitamin D level that we ordered through their advanced beneficiary notice, just so you guys know that. You know, or I'm just going to make sure that they're on vitamin D as well. So I'm going to be more concerned about their calcium intake. But it was an epidemiologic study. Reasonably convincing enough for us to at least talk about it, but overall the relative risk is low. And so if they've had bleeding ulcers before, they've had erosive esophagitis, if they've got Barrett esophagus, you know, the benefits of taking the PPI clearly outweigh the risks, and the risks can be managed. If you don't need to be on a PPI, don't be on a PPI. You know, if you can step down your therapy, step down your therapy. All right. Well, thank you very much. I appreciate you guys asking me to come here, and I'm going to run off to SLU to do my endoscopy. I used to be here on Wednesdays, but they flipped my schedule. Alrighty. Sure. Let me see. Okay, we'll do alt file. Save as. The problem is the. Let me see if I can. No. Oh, here we go. So, C. I think if it's just C, they'll just go to desktop on it. Or can I keep going down? It won't. You can't. I already tried that. It's not working. You have to do it by this. So, desktop there. Alright, I'll save. Then we'll do alt file, exit. C. C. Oops. What did I do? Yeah, I wish I could. How do I get there?
You're not getting it?
Well, yeah, this doesn't work. See, it works up here,
Yeah.
but it doesn't work here. I promise. I'm actually
Oh,
fairly.
this-
Is it there now?
What's on?
Actually, no. Yeah, I already
Oh,
put it.
you
It's
did it?
already
Oh,
there.
oh,
Yeah, it's
okay.
already there. I'm just trying to. If I can close it out, and then I gotta get the little. Got the. No, that's fully charged. This one right here? No, that's that one right there, okay.
Do you
Now we can.
Is there anything like you suggest in that type 1 diabetics who have all this gastroparesis?
The best drug that we have is metoclopramide and diet. Sadly, yeah. So for
a big
them,
problem,
it's
so,
really
yeah.
much more about symptom control, because we really don't have good prokinetic agents. But if we do, like control things like their constipation, their upper symptoms seem to be a little bit less severe, so I do try to fairly aggressively control their constipation.
We give them Colace, but they gotta be on the Colace like
Yeah, and you know what?
prophylactic
Well,
anyway.
interesting, Colace, there's actually a study done in elders, not in pregnant patients, but showed that Colace was no better than placebo.
I believe
So,
it. I believe it.
yeah. That being said, I ended up with a C-section.